So termination of a movement depends on the cerebellum. So if there is damage in the cerebellum, then there will be some overshoots of the movement or undershoot of the movement. Okay? Usually the patients have oscillating movements around the target, so this way. Okay, to reach the object. So at first he or she passes the mark, then they try to correct the movement. Again, the corrected movement is not precise. Okay, so again we have actually overshoot, and this causes actually oscillation of the movement. So this is tested in a clinical examination test like this. So you ask the patient to put the finger on their nose like this. Okay? The patient usually moves this way. Okay? So there is oscillation when they approach the target. Okay? So damage to the cerebellum may cause overshoots of a movement or oscillation of a movement. Sometimes there is action tremor. So at rest there is no tremor, but when they want to move their hand, there is oscillation in the arm or in the movement. Okay? So the cerebellum is also important for ballistic movements, the movements that are very fast. So there cannot be any regulation during the movement. Okay, so we call them ballistic movements, like saccades. You know, saccades, eye movements that are very fast. Okay? So based on this, damage to the cerebellum may cause slow development of movement, weak force, slow turn of the movement may cause dysmetria or overshooting of the movement. And for ballistic movements, the automatism is lost. Okay, so let's see some of the clinical features. The first one is called ataxia. Ataxia. It's uncoordinated movement. Okay, in any aspect, in rate, in range, in force, in direction. So we call this. So any uncoordination in any of these is called ataxia. It can be limb ataxia or truncal ataxia. Limb ataxia is represented by dysmetria, pass pointing or intention tremor. So dysmetria means any mistake in targeting an object. Okay? So for example, pass pointing or overshooting, undershooting, so all of these words are used for ataxia, for limb ataxia. We call them generally dysmetria, okay? Where the patient undershoot or overshoot the target. So pass pointing is another name. Truncal ataxia that causes a wide base gait, a wide base drunken sailor gait. So I told you before, the patient tends to put their legs wide, so this way they want to keep their balance. Okay? So it's truncal ataxia. So there will be delay in initiation of the movement because for the onset of the movement, the cerebellum is important. Damage to the cerebellum delays movements. Right? Here, when there is abnormal functioning of the cerebellum, you can see that the movement starts later and then normal side of it. Okay? So the other one is the composition of movement. So dysmetria of the composition of the movement also. So finger to nose test. Finger to nose test. Okay? So instead of having the direct and straight path, the patient usually uses an oscillating movement like this. Okay? And when the finger approaches the nose, you can see that oscillation gets higher, gets more, right? So we call this decomposition of movement. Decomposition means, so when you want to do this movement, so you use your shoulder, your elbow, your wrist, all at the same time. Okay? But with the cerebellar damage, usually the patient moves each part separately. First, they shoot the shoulder, then elbow, then wrist. Okay? So, this is called decomposition. Decomposition of movement. Rebound phenomenon is different, is another sign. So, you ask the patient to stretch their hand, their arm. So, you hit the arm. Usually, it should come back to the normal position. But in a patient with cerebellar damage, usually it overshoots. Okay? So if you hit, it goes on. Okay? Or if you, for example, ask the patient to hit the arm on the chest, and then you pull the arm and release it, the patient usually hits the arm to the chest. Okay? So rebound phenomenon also happens in cerebellar damage. Another one is disdiadosis or dyskinesia. So when there is a problem with alternating movements like this, supination, pronation, repetitive, possibly intermittent pronation and supination. Okay, so this should be rhythmic and smooth. But if there is cerebellar damage, the patient cannot do this regularly. Okay, so you can see that the rhythm is lost actually. So you can actually think about the function of the cerebellum and relate some of these to a specific area of the cerebellum that is damaged. For example, I told you before that for progression of movement, progression from one movement to the next one, which one of the cerebellum is more important?
Like
area related to planning.
lateral.
Lateral. So if there is problem in the rhythmic movements like this, okay, so we call this diadocokination, then we can infer that probably there is a problem in the lateral zone of the cell. If you test the patient and see that there is a problem in eye movements, smooth person eye movements, then you can identify that the problem is in the nodular area. Right? So by testing the movements of the patient, you can actually find the location of damage. Another one is dysarthria, problem with talking. Talking is a type of movement. So the start and ending of the movement is important in the speed, right? So a patient with cerebellar damage usually has problem with articulation of words. We call this dysarthria. So the intensity and duration of words on the peripheral side of the visual field. So when you ask the patient to fix their eyes on a peripheral object, there will be oscillation of the eyes. So it's similar to oscillation of movements in the arm. Okay? The same also happens in the eye movements. So with follicular nodular damage, we'll see problem in the eye movements. It can be in the form of nystagmus. And I told you that even in the resting state, the deep cerebellar nuclei provide continuous signals to targets. Targets are motor systems. So when there is damage to the cerebellum, this resting state signals are lost. So motor systems are not activated by the cerebellum. So the result will be hypotonia. The tone of the muscles are usually depressed when there is damage to the cerebellum. So damage to the vestibular cerebellum may cause ataxia, problems in balance, and nystagmus. It's clear, right? Vestibular cerebellum. Damage to the vermis and fastigial nucleus causes problem with control of axial and truncal muscles. Problem with posture and also scanning speech. Right? Because the mouth is related to the awareness. And damage to, the phase is related to the intermediate zones, okay? As ischial nucleus. And damage to the cerebellum may cause delays in initiating movements and decomposition of movements. So decomposition of movements signify a problem in cerebellum. Problems in initiating movement may infer a problem in cerebellum. Scanning speed is related to ischial nucleus awareness. Truncal ataxia, vestibular cerebellum, right? And so on. So now let me talk about the basal ganglia, which is another side loop of the motor system. So I think that you now have an understanding of the motor system. We have the simplest type of movements in the spinal cord, which are the reflexes, right? You know, we have some tracts that originate from the brainstem, like the cerebrospinal, tectospinal, reticulospinal. So they are involved in balance and posture. We have other pathways that originate from the cortex, corticospinal tract, right? They are important for voluntary movements, right? We have also red nucleus, which is the origin of cerebrospinal tract. So it provides a parallel pathway to the corticospinal tract. It's also important for regulation or movement of the distal part of the arms, fingers, right? So these are the main motor pathways. But cerebellum is a side loop. It receives command from these systems, send back the signals to the motor system. It doesn't provide direct information to muscles or to alpha motor neurons in the spinal cord. We don't have cerebellospinal tract. Do we have? No. We don't have cerebellospinal tract. Cerebellum only provides input to motor systems. So it's a side loop. Another side loop is basal ganglia or basal nuclei. In anatomy they call it basal nuclei. In physiology we say basal ganglia. Okay? So it receives information from the cortex or motor system, send back the information to the motor system. There is no direct connection between the basal ganglia and muscles or alpha motor neurons in the spine. Again, relation is between motor systems and basal. So it's an accessory motor system. It receives input from cortex and returns the signals to the cortex. The neurons discharge before initiation of movements. Right? So they are important for programming and planning of information mainly. Because they start their function just before the action. Right? So, you know the basal ganglia. Can you name them? Some of them? Which of these name some of the basal ganglia? We have them in your anatomy, right? So I try. Actually, I help you. First one is caudate. Caudate nucleus. What else? So you only focus on midterm, right?
Yes.
Yes. But you should also study for final, okay? You should be prepared for that. After that, inshallah. So, caudate, putamen, globus pallidus, two parts. External, internal, what else? Substantial nigra has two parts. No. Compactor, reticulum. Okay, what else? Putamen, okay. One more.
Dentate.
Dentate is for cerebellum. Caudate, putamen. substantia nigra, globus pallidus, and subthalamic nucleus. Subthalamic nucleus. So, you know that caudate and putamen form striatum, right? So, a massive and large body located just in the core of the brain is the striatum, right? It has caudate and putamen. And you know that fibers go, cortical fibers go through the gap between the caudate and putamen. What do we call that? What do we call a gap between the caudate and putamen? The fibers go through this gap downward. What do we call that? What's the name? Internal capsule. So part of the internal capsule is located between the caudate and putamen. Another part is between the caudate and thalamus. Right? So it has anterior leaf, posterior leaf. So here you can see connection of neurons between the basal ganglia. So this one is from Guyton book. This one is from Canada. Okay, so first let's see this one. So from cortex, some fibers go to caudate and putamen. They release acetylcholine, so, but mainly glutamate. Okay, it's not mentioned in Guyton book. In Guyton book, it's mentioned that they release acetylcholine, but the main neurotransmitter here is glutamate. Right. From putamen and caudate, we have neurons that go to globus pallidus. They release GABA. So, caudate and putamen release GABA. Globus pallidus, external, internal, they release also GABA. So they send fibers to substantia nigra or to thalamus. They all release GABA. Substantia nigra, much compactor, send fibers to caudate and putamen. They release So what are the neurotransmitters in the basal ganglia? Glutamate, GABA, acetylcholine, and glutamate, right? So there are also other fibers that enter the basal ganglia from other places, especially from brainstem. They release norepinephrine, serotonin, and caffeine. So now let's see specific connection between these neurons. First of all, let's see this one. It starts from cortex, right? It goes to putamen and caudate. Caudate is not shown here, but it's the same. Okay, so parallel fibers go to caudate and putamen. Where is glutamate? So the red one, it means excitatory fiber. So it excites putamen. From putamen, we have two pathways. Direct pathway, indirect pathway. Direct pathway goes directly to globus pallidus internal. It releases GABA. So putamen is activated by cortex, inhibits globus pallidus internal. Globus pallidus internal, in turn, is inhibitory. It inhibits thalamus. And from thalamus, fibers go to cortex. So it's a loop. Right? In this loop, we have two inhibitory neurons. And you can use mathematical operations. So when you have two negative signs multiplied by each other, it will give us a positive relation. Okay? So the whole loop will become excited. So cortex activates putamen, putamen inhibits globus pallidus internal. So after inhibition, it cannot inhibit thalamus. So thalamus excites the cortex. So the general function of this loop is excitation of the cortex. So cortex starts everything, and it is excited more. Right? So this side loop actually increases the activity of the cortex. Okay, now let's see indirect pathway. Cortex activates putamen. Putamen sends fibers to globus pallidus internal indirectly through globus pallidus external. So first they go to external part. This one is inhibited. So this one cannot inhibit globus pallidus internal. Right? Globus pallidus internal inhibits thalamus. Thalamus cannot excite the cortex. Activity in the cortex decreases. So, indirect pathway is generally inhibitory, right? But it has two parts. You can see in another way. Globus pallidus external is inhibited. It can't inhibit substantia nigra, so it is released. This is excitatory. It excites globus pallidus internal. This one inhibits thalamus. Thalamus cannot excite the cortex again. Right? So, direct pathway is excitatory. Indirect pathway is inhibitory. So I told you that neurons here are activated just before the action. So cortex sends a signal to muscles. One version of the signal comes to the basal ganglia. It returns to the cortex and helps the cortex to promote the action. Right? So why do we have two pathways, one excitatory, one inhibitory? We don't know. Okay? The answer is not clear. There are still studies to clear this confusion, right? So, but we make it simple. We say like this. Direct pathway activates the cortex to promote wanted movement or desired movement. Indirect pathway inhibits the cortex to prevent unwanted movements. So imagine like this. You want to do this movement. So this is your desired movement. Okay? During this movement, all other movements should be suppressed. So you cannot do, for example, this movement during this one. Okay? So this is an unwanted movement when you want to do this. Okay? So, actually this is only a simplification of the issue. The real, actually state is not clear, okay? So, we say that direct pathway promotes wanted movements, desired movement, indirect pathway, suppresses unwanted movements. Okay. So, from substantia nigra plus compacta, we have dopaminergic neurons to the coded putamen. Dopamine has two different types of receptors. D1-like receptor and D2-like receptor. You know this? One is excitatory, two is inhibitory. So, neurotransmitter which is released here is only dopamine. But it can act on two different types of receptors, D1 or D2-like. Okay, so you know that D1-like receptor includes D1 and D2. No, D5. These two are D1-like receptors. But D2-like receptors include D2, D3, D4. So we have 5 different types of dopamine receptors. D2, 3, 4 are called D2-like. D1 and D5 are called D1-like. These are excitatory, these are inhibitory, right? So, D1-like receptors are found on neurons that are in direct pathways. So direct pathway neurons express D1-like receptors. Indirect pathway neurons
D2.
express D2-like receptors. So dopamine is released, activates direct pathway, inhibits
D2.
inhibit. So when we want to have a movement, dopamine is released and helps the initiation of movement, regulate the movement by activation of direct and inhibition of indirect. So if there is damage in substantia nigra or cortical pattern, what happens? Parkinson's. You'll see that later. Okay. So you have hyperdirect pathway. I don't want to talk about this. Okay, so you should remember only direct pathway and indirect.
Direct is excitatory, indirect is inhibitory.
Yes. Okay. So functionally, that circuit has two components. A circuit that goes from cortex to putamen, circulates in the basal ganglia and goes back to the cortex. A parallel pathway goes to caudate instead of putamen. I told you that we have fibers that go to putamen and caudate, right? So some of these pathways originate from cortex, go to putamen, and then goes back. Another fiber goes to caudate. From caudate, they go to other basal ganglia and go to cortex, right? So we have putamen circuit, caudate circuit. For control of movement, they are different. Putamen circuit is mainly important for regulation of complex patterns of motor activities. Complex patterns of motor activities. Learned motor activities. Motor activities that you have already learned, right? Like in your book mentioned, scissoring a piece of paper, hammering a nail, okay, shooting a basketball, passing a football, okay. So every movement that we learn, and these movements are complex. Scissoring is a very complex movement, okay? Playing piano is a complex movement. Hammering a nail. So you cannot ask your kid to do this because it's very dangerous for them, right? So it's a complex movement, okay? It needs high level of consciousness and high level of control on the muscle, right? So these type of movements are regulated and are controlled by putamen circuit. So everything starts from different areas of cortex, prefrontal for decision making, for action selection, premotor and supplementary motor area for planning, and somatosensory area for sensory feedback. Okay, so from here, information goes to putamen, other nuclei in the circuit, but the output goes to primary motor cortex. Primary motor cortex is important for performance of an action, right? So input comes from areas of the cortex related to planning, but output goes to area of the cortex related to execution, performance, primary motor cortex. So, from premotor and supplementary motor area and somatic areas, input fibers come to the basal ganglia, output go to primary motor cortex. For complex movements, right? Damage in the putamen circuit may cause uncoordination of movements, complex movements. For example, if we consider writing, which is a complex movement, the handwriting becomes crude. Okay, you can see this in Parkinson's disease patients. They cannot write something very well like previous condition, okay, in normal condition. So in this pathway, lesion in globus pallidus causes continuous writhing movements called apoptosis. So it's like this. Continuous writhing movements of hand, right, arm, neck, or face. We call this apoptosis. When it happens? When there is damage to globus pallidus. Damage or lesion in subthalamic nucleus indirectly causes hemiballistus, swinging movements of the entire arm. Okay? So this movement is uncompressed. The patient doesn't want to do this, but the arm movements. Okay? Swinging movements. Lesions in putamen causes a condition called chorea, which is fleeting movements of the hand. So like this. Okay? So fleeting movements of hand or like in face, okay? Or other body parts. Lesions in substantial minor causes Parkinson's, which is represented by rigidity, achnesia, tremors. Tremors that happens here is different from the cerebellum tremor. We'll see that. Okay, the other pathway, the other circuit was caudate circuit. Right? Fibers go from cortex to caudate, other nuclei, and go back to the cortex. Right? So this circuit is mainly important for cognitive control of motor activity. So let's see. We start from primary motor cortex and premotor and supplementary motor area and somatosensory areas of the brain. They go to caudate, other basal ganglia, thalamus, prefrontal cortex. Right? Not to motor cortex. Prefrontal cortex. Prefrontal cortex is the location of the brain important for thinking, for problem solving, for judgment, action selection, goal setting. Right? So, motor cortex sends input to basal ganglia to prefrontal cortex. So this is important for cognitive control of motor behavior. So it's not related to the action itself, but it's related to selection of action. Right? So for example, you want to reach this one, but you're sure you cannot reach. Okay? So you think about that. Okay, I use this chair, I go up, and then I can reach. So in this example, you also moved your body. And this movement was voluntary, but the type of the movement was different. That was not a simple movement like a reaching. Right? So you decided about a course of action. What was the action? Bringing the chair, putting off your shoes, going up, then reaching. Right? So this course of action was actually selected by prefrontal cortex. And for this type of selection, you need the basal ganglia circuit. Which part of the basal ganglia? Caudate. The circuit that goes first to caudate and then to other basal ganglia. Then come back to the prefrontal cortex. Okay, so cutaneous circuit for complex movements. Learn complex movements. Caudate circuit for cognitive control. Cognitive means action that needs thinking. Right? So, okay, basal ganglia are important for timing and the scaling of the intensity of movement. Okay, Parkinson's disease happens when we have widespread lesions in substantial neuromuscular pattern. Dopaminergic neurons are lost. So, a lot of things happen. Rigidity, right? Rigidity means actually resistance against passive movement of body parts. So when you want to move the arm of the patient, you can see that it's rigid. It doesn't move easily. Okay, rigidity. Involuntary tremor. It's different from cerebellar tremor. Cerebellar tremor was
Voluntary tremor.
no, we call that intention tremor. Whenever the patient wants to move their body, tremor starts.
Involuntary when they don't move.
Yeah. But here we have tremor at rest. So, even in conditions that the patient doesn't want to move their hand or their body, they have continuous tremor. Okay? So, involuntary tremor. Difficulty in initiation of movement, achingation. The patient wants to move, they want to step forward and start their walking movement, but there is a delay, okay? They cannot move. They should actually force their mind and try more to start their movement. Okay? So we call this akinesia. We have also bradykinesia. Bradykinesia means so they started their movement, okay, with a lot of effort. But when they start, the movement is small and slow. So the step is small and slow. Okay? Bradykinesia. Postural instability leads to poor balance. So balance is lost also. Dysphagia, speech disorders, gait disorders, fatigue, or other clinical features. For treatment, so dopamine is lost, there is no dopamine in the brain, or there is a shortage of dopamine. You should increase dopamine level in the brain. How can we inject dopamine?
No.
Why not?
Take a small.
It's a small?
Yeah.
No, it's
Yeah.
not.
Make it
You have a
small.
smaller drug actually.
Yeah.
So, because dopamine is degraded in the body very fast. It doesn't reach the brain. Okay? When you inject, it is degraded very fast. Because we have several enzymes to break the dopamine. What are those enzymes? You should know this from biochemistry. Catechol-O-G transferase, COMT, monoamine oxidase, MAO, MAO. You should know this, I know. I know that you should know this. Okay? So, dopamine is degraded very fast, so cannot be injected. Instead of that, we inject or we use L-dopa, which is a precursor of dopamine. So it is converted to dopamine inside the brain. Right? So it's converted in the brain into dopamine. It restores the normal balance between inhibition and excitation. So it actually decreases the symptoms of the Parkinson's. Another drug is L3-p2, which inhibits NAO, monoamine oxidase, which degrades the dopamine. So it slows destruction of dopamine secreted neurons also. Transplantation of fetal dopamine cells. If you transplant some dopamine secreting cells from a fetus to the brain, it can provide dopamine and relieve the symptoms. But usually after 1 month, these cells are also degraded. They are also lost. Because we have actually immune reaction, right? Immune reaction to these cells. But the best one, I mean, the newest type of treatment for Parkinson's disease is using some type of electrical stimulation in the brain. We call that DBS. Deep brain stimulation. brain stimulation. So you know that in the basal ganglia, we have a balance between excitation and inhibition. Actually, this balance is very complex. There are several types of inhibitory neurons and some type of excitatory neurons. They have a specific relation with each other. So one of these nuclei is missing now. Which one? Substantial nuclei, right? So the balance is interrupted. So you may activate other nuclei to regain the balance. Okay, for example, by excitation of globus pallidus, or by stimulation of the subthalamic nucleus. So usually, by electrical, so actually this one is a surgical treatment, so you can remove part of the thalamus. Okay, this one is one of the treatment, but the other one is easier. I'm talking about that. So, by a stimulation of some part of the basal ganglia, you can regain the balance, and this way you can decrease the symptoms of the Parkinson's disease. Okay? Actually, my work in Tehran University is about DBS. I use DBS for treatment of addiction, but in rat models. Okay? I give the rats morphine, make them addicted, and then, so it's like an addicted patient, right? Then I stimulate some areas of the brain by DBS, and actually we are working on that. And we have seen that by stimulation of several areas in the brain, we can decrease their desire for using drug. Okay? One of those areas is orbitofrontal cortex. Another area we identify is lateral hypothalamus. Now, these days, actually we are at the end of another study, stimulated cingulate cortex. Cingulate cortex stimulation also decreases the craving, their desire for using drugs. Okay. So, another disease is Huntington disease, which happens. So you can see the symptoms happens because of the loss of GABA neurons in caudate and putamen. Okay, and also acetylcholine neurons. So when acetylcholine is missing, the result is dementia. You know, the patient doesn't remember anything, cannot understand anything, all that dementia. Okay? So acetylcholine neurons are important for that. When there is a loss of acetylcholine, the patient usually shows dementia. So in order to actually in our laboratory, in our labs, sometimes we want to make a rat model of Alzheimer's disease. So in Alzheimer's disease, there is a problem with memory and learning, right? So the patient cannot remember anything. So one way for induction of memory loss in a rat is to destroy acetylcholinergic neurons. So you know that in the basal forebrain we have some collection of acetylcholine neurons. If you destroy these neurons, the patient doesn't remember anything. Okay, how can we test it? By using some mazes, right? So we train a rat to find the goal in a maze. Okay, so it gets better and better after some trials. After that, we can destroy the acetylcholinergic neurons. Then put them again in the maze. They cannot find the way. Okay, so they cannot remember the way. Okay, so acetylcholine is important for learning and memory. If there is a loss, dementia happens, which is one feature in Huntington disease. And GABA neurons are also present in caudate and putamen. Loss of GABA neurons causes distortion of movements. distortional movements of it. So that's all about basal ganglia. We started at 9:20 and we finished at 11:20. So, any question for this session? Yeah. So other students that came